Hello, everyone. It is a great pleasure today to be with you and to discuss all together because we have such a very interesting topic, something that is becoming the hottest topic in the interventional cardiology field. We are going to talk of a paper recently published on EuroIntervention because this is EA join IJ on air. So this is our special episode, and you can comment and discuss with our hashtag EIJ on air. Don't forget because we are waiting for your questions. And the paper is leaflet modification techniques to mitigate coronary obstruction risk during TAVI. And we have the first author, Sunny Goel, that is with us. Hello, Sunny. Great pleasure
Hi
of being
guys,
with you today. Thank
welcome.
you. Dr. Goel, you know, is a professor of medicine at the Icahn School of Medicine at Mount Sinai and Mount Sinai Heart, Zina and Michael E. Wiener Cardiovascular Institute. And we are going to talk about this very interesting topic because we know that it's becoming a need, an unmet need, and we need to face it. So, Sunny, what clinical or procedural need prompt you to explore and compare leaflet modification techniques?
Thank you, Alex. So, welcome everybody. So, as you know, this coronary obstruction is a deadly complication during TAVR, especially in valve-in-valve cases and complex anatomical native valve cases. The mortality rate can reach up to 50% for these people who have an acute coronary obstruction. So that's where the impetus came to look at this leaflet modification for coronary protection. The traditional techniques like chimney stenting have limitations, as we know, because it has more. There is need for reintervention is very high. Plus, there is unpredictability, and it's not particularly feasible in patients with low coronary heights, narrow sinuses, or if the THV commissures are not aligned. So that is why the leaflet modification techniques have come into place to solve this problem. And that is why we looked at this paper, particularly to look at all the techniques available right now for the interventional cardiologist and structural interventionalist to help these people who need leaflet modification before they get a TAVI.
Yes. As you said, we are coming to collect all the data that we have in our cath labs, and Basilica is probably the well-established technique that we have. What would you say are its key strengths and what limitations persist in real-world use of the Basilica technique?
Thank you. So Basilica is one of the earliest technique that was described by the investigators to do the leaflet modification. Its strengths lie in its precision and its ability to lacerate the native or bioprosthetic leaflets to maintain the coronary patency without requiring any stenting. It is, mechanically rational, and it has been shown to be reproducible in high volume centers. There is a lot of data. There is the Basilica ID trial that looked at 60 patients, and they were able to achieve a success rate of close to 95%, which was reciprocated in the Basilica registry as well. They looked at close to 200 patients that underwent either a single leaflet Basilica or doppio. That is common call where they do the leaflet laceration for both leaflets. 94% success rate, and they were able to reproduce this technique and with consistently, and it showed good results. The challenges remains it's technically demanding, of course. It requires a lot of equipment, specialized equipment, and need operator expertise. And plus, if the leaflet is very calcified, plus if the commissures are not aligned, or in TAV cases, it might not be able to give you the good result and give you the perfect laceration that you're looking for. The learning curve is a little bit high, and the procedural time might also become higher for the case. So those are some of the limitations.
Yes, but also beside the techniques that we built with our fantasy, we have also now devices that are coming on the field, and the only approved, FDA approved, is the shortcut. Shortcut is a device that has also a study published. And do you see it as a viable alternative or a complementary tool to Basilica?
Definitely complementary, definitely. I mean, they both have their spaces. I think shortcut is a very promising and simplified alternative. It is only limited for bioprosthetic valve-in-valve settings. We cannot use the shortcut device as we know yet for the native leaflet. Unlike Basilica, which involves electrosurgical laceration and traversal, shortcut is more of a mechanical leaflet splitting directly through the valve frame. It is more user-friendly and potentially more scalable. I think the learning curve is very short because, in the original trial for the shortcut that was published in EuroIntervention actually last year, they only had centers that have not done less than 2 basilicas, and we were able to use this device rapidly and got good result. Again, the results were very consistent, and they were able to lacerate all the leaflets, and plus they were able to do both leaflets at the same time using the same wire. So there's no need for exchanging different equipments. You can use the same wire and one catheter, and use the transcatheter sheath that you use to deliver the valve. You can use the same sheath to deliver this device and do the splitting of the leaflets, either 1 or 2 leaflets, and then deploy your valve. So I would definitely see it as a complementary tool with a potential for more uptake, and expanding its indication to even other places like native leaflets, or for basically in the mitral space either. So I think they both have their space, and I think Basilica is well established, but the shortcut is definitely here to stay, and give us more options in especially in bioprosthetic valve-in-valve settings.
Yes, and we have also Babasilica and Unicorn. I saw recently published also Babicorn,
Yes.
and so we are developing a lot of techniques. Which one do you prefer? You have something?
Yeah, I mean, the more we're gonna do, we're gonna run out of the names: Superman, Baby Corn, Lampoon, Basilica, BA Basilica. So, but these techniques are all, the interventionalists are thinking out of the box, and they're trying to come up with solutions which are not addressed by the current techniques, such as the Basilica, where the leaflet splaying might not be enough, especially in TAV cases, or the newer generation transcatheter valves that has pinned leaflet. If you try to deploy a new valve in old TAVI, the leaflets might get pinned against the leaflet, against the old TAVI, and then will not be inadequate. There will be inadequate splaying of the leaflet, especially if you do traditional basilica. That's where the BA basilica comes in handy, especially with stiff non-compliant bioprosthetic leaflets, where the basilica fails to achieve the full splay. It can help you give a more precise expended or displaying of the leaflets, I would say. Unicorn, I think, is up and coming, and I think a lot of people are moving from Basilica to Unicorn. It might be, an answer to in cases where you are concerned about inadequate splaying, where you can target only one leaflet. Again, this is only can be done with one leaflet. You cannot do 2 leaflets at one time. You basically puncture the leaflet, you expand, you you do it with a non-compliant balloon, you make a bigger hole, and then you deploy the valve through the same hole. What you're basically doing is you're avulsing the leaflet. The only drawback is you don't know where that leaflet is going to be splayed or avulsed. It's not controlled. I would only advise you to do it in patients with bioprosthetic leaflets, not in the native leaflets. And again, it doesn't solve the problem if you have very heavily calcified leaflet, or the tip leaflet or a big floppy leaflet, where it can again still go into the left coronary system and can cause problems. So, again, Unicorn is more simpler. It's can be done on the same hole, and you don't have to do snaring and then cutting and all the stuff. You can just puncture and then dilate and deploy it through the same hole. So definitely Unicorn has some data now, mostly limited to case report, but definitely will be interesting to see its role in future.
Yeah, yeah. And yes, we are talking about this topic because this is an unmet need. But in your experience, when is leaflet modification essential? And when can simpler strategies like the chimney stenting be enough?
So I think leaflet modification is going to explode even further. We're not talking only about in patients who have a high risk of coronary obstruction. Nowadays, we're talking about future access to the coronaries. Especially in patients who have borderline cases of coronary obstruction, where you do, thinking of doing coronary chimney stenting, which is, I think, in my opinion, is quite unpredictable because you're going to deploy the stent behind the stent frame. So there's a higher risk of the stent fracture or coronary reaccess. Plus, you're committing patients to lifelong anticoagulation or antiplatelet therapy because you don't know what is going to happen with the stent. So chimney stenting definitely was a preferred approach before all these techniques came in because it's simpler, easier, and it's a good bailout strategy. But I think stenting through the frame is probably the way to go. And this basilica and other leaflet modification technique definitely helps you allow and put in the stent through the valve frame, which is more mechanistically and theoretically makes more sense. So I think leaflet modification definitely has a role in TAV, where corneal obstruction remains one of the most difficult and unsolved challenge. Plus, in patients who have narrow new sinuses or inability to reaccess coronaries after a second THV implant, definitely involves leaflet modification technique. So, and chimney stenting can be effective in certain anatomies, especially where they have large sinuses or when you have good alignment of the THV. Again, these are all complementary techniques, but I would rather prefer a leaflet modification rather than doing chimney stenting because of, future future adoption and the future use of it, basically the benefit that you're going to reap in future with the leaflet modification up in front.
Yeah, totally. And about the future, how do you envision the role of new technologies or artificial intelligence in improving pre-procedural risk assessment for coronary obstruction?
So there are a lot of upcoming techniques. I think we touched base on shortcut device. There is a splitter device. There are some laser technologies that are up and coming that can actually and then there is other techniques that are developed like cathedral, telltale, which is dedicated basilica device. So there are a lot of devices that are coming in the market to address this problem. But again, the widespread adoption is a problem. We think we need a little bit more simpler technique, which can be widely adopted. I think shortcut has a role to do it, especially in valve cases. And then AI definitely can help us, help, procedural planning. I know we use 3Mentio to risk predict, and then we do our simulation to put in the to put in the valve and do see the risk of coronary obstruction. But AI can definitely refine the risk stratification by integrating the large databases. It can identify the subtle predictors of obstruction, which are not seen on the regular CT scan, and even recommending optimal leaflet modification technique. Maybe it can tell, hey, this case is good for basilica, this case is good for shortcut, this case is good for unicorn. So I think AI definitely has a role. Once we get more data and we can integrate into large database, it can definitely help us. Plus, it can, also measure us the VTC distances, leaflet thicknesses, play angles that can help us decide which patients will benefit from leaflet modification and which techniques specifically.
Yes. And last question, Sunny, because thanks so much about this amazing discussion and sharing your terrific experience about it. What is needed most? Better tools, more training by the interventionist? We are in every Congress now, there is a simulation cath lab. So we can try new tools, we can try modification techniques or wider adoption of the existing techniques.
Yeah, I think you touched on all the good points. I think we need all three. We need better tools, of course. We need more simplified, better tools. And I think Telltale has a promise to do it. Shortcut has a promise to do it. We need better techniques. We need more training. We need to make this technique widely adoptable. So we need to have more experienced operators who can train places where they're not doing it. And again, all this, we see all these patients with coronary obstruction, but there are a lot of people who don't even go for the procedure because they were deemed too high risk, either for surgery or TAV in TAV or valve in valve TAVR, because there's a high risk of obstruction. These patients are managed medically. There are a lot of people that are not being even we don't even know about those. So I think more wider adoption of the existing techniques and more training with better tools definitely can close this gap. And I think all three needs to be done simultaneously.
Yes, totally agree. And I think that societies should be involved in this to shape the future training about this very important topic. Thanks so
That's great.
much, Sunny. Great,
Thank you. My
really a great
pleasure.
pleasure. Thank you very much. And
Been a
thank you
pleasure.
for all the colleagues. We are always open to your questions, even after the session. And thanks so much for being with us. Thank you. And see you soon for the next EIJ on air. Bye-bye. Thank you.
Thank you, guys. Thanks.